Hello, and welcome to our webcast. I'm Jamie Pennington with Moss Adams, and I am getting us started for today's session, What Hospitals Need to Know About CMS Transmittal 18. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
And now I would like to introduce today's presenters from Moss Adams, Michael Newell, partner, Eric Lucas, managing director, and Jonathan Mason, director. Their bios and contact information are located in your webcast console for your convenience. And now I would like to turn the floor over to Mike to get the presentation started. Mike?
Thank you, Jamie. Well, I want to thank everyone for joining today. We've got a big group, and judging from the size of the audience, I think it's safe to say that there's significant interest in the changes that were recently released by CMS in the form of Transmittal 18. If you've been following this issue, either through our numerous prior webcasts or through other outlets, you know this has been a long time coming. And much of what we'll cover today, certainly as it relates to the DISH and uncompensated care reporting particularly, these changes are also being shaped by the several years of audits related to the uncompensated care piece and many years of audits and thousands of subsequent appeals related to DISH over the years, and in fact, including Medicare bad debts as well. In many cases, not all, but some of these requirements are familiar as they've been incorporated into audits over time. However, that has been on a very small scale, as in most cases, only the sample patients were involved in those items. Now hospitals will be required to present at cost report filings significant and important information, really for the first time, for all patients included in the DISH and Worksheet S10 reporting. And in addition to that, we'll also spend some time on changes related to the submission of data related to Medicare bad debts, and those changes were also laid out in the transmittal. So simply put, there's a lot here. So our hope today is to get a firm foundation established so that we can all continue to reflect on what we need to mine in our data, how to retrieve it, how to ensure we have adequate quality control over the process, and what we report is complete and compliant, and ultimately hospitals receive all the reimbursement that they're legally entitled to. So I would say during the presentation, fire away with questions, and we'll try to hit some along the way if we can, and certainly at the end with time permitting. Otherwise, we'll follow up on all questions as we have in the past at a later date. And also, please don't hesitate to reach out to any of us to discuss, any of this further. So we're going to walk through sort of in these 5 big pieces: Medicare DISH, and then the UC reporting, the exhibit changes for Medicare bad debts. And I think those are probably the biggest issues in Transmittal 18. But there are a number of other important items that we're going to walk through, including GME and some other significant stuff. So with that, I would say we're going to get to our first polling question before we begin. So I'm going to turn that back over to Jamie to lead us through that.
Our first polling question is, have you put together a team of reimbursement and decision support staff to map out a plan to obtain all of the new data required in Transmittal 18? Your answer options are yes, no, unsure, or not applicable. I'll give you a few moments to respond. To respond, please click the radio button next to the answer you choose and hit submit. If you can't see the submit button, please enlarge your slide area. We'll give it another minute or so. All right, I think we have quite a few responses. Mike?
So if you look at the responses, about a third of you feel like you're in pretty good shape. There's still a pretty good sized crowd that kind of know or not really sure. So I'm hoping that will help with that as we get through the presentation, and then kind of you can assess your answer again at the end, and that'll maybe help formulate where you go from there. So with that, why don't we go ahead and dive in, and I'm going to turn this over now to Jonathan Mason.
All right, thanks, Mike. So I wanted to start out discussing the Medicare DISH revisions in Transmittal 18. And so before we get to the new required template, I wanted to first mention some updates to S2 lines 24 and 25, and that's the columns 1 through 6. Before, these were very short instructions regarding where to populate in-state, out-of-state paid, and unpaid days, along with HMO and L&D days. CMS added specific language for each column now, and I'll read it from the slide as I think it's an important point they added. So each category of day is furnished to a patient eligible for inpatient benefits under an approved state Medicaid plan, or eligible for inpatient benefits or regarded as such under a waiver authorized under Section 1115A2 of the Act on that day. So as many of you know, there have been recent court decisions in the last few years in favor of the provider regarding certain Medicaid Section 1115 waiver days and their inclusion in the DISH fraction. And this new language specifically addresses these waiver days. Now, CMS has proposed to tighten the qualifications under such a waiver in the past 2 years of rulemaking, only to not adopt those proposals in the end. And actually, our understanding is that there's a new proposed rule from CMS on the treatment of these 1115 waiver days in the DISH calculation that could be released any day. We don't know the contents of the proposal, but based on the history, it seems likely that CMS will again attempt to tighten the qualification of patients eligible under those waivers. So this is something we would encourage providers to keep a lookout for and determine how this might impact their DISH calculation. CMS did release a new required template for the Medicaid patient detail that is required for any DISH eligible hospital at the time of cost report filing. And so this new template is required for for any cost report beginning on or after 10/1/2022. So only hospitals that are not DISH eligible or where their sole community E-Part A line 48 is greater than line 47 do not have to complete this new template. So let's dive in and look at some of these requirements. So here's a copy of the new Exhibit 3A. Previously, the requirement was some demographic information and a number of the days for each patient that tied back to S2. So you can see that CMS has really expanded what they want to see with the DISH listing now, as there are now 18 columns for each record. And so let's look at a little bit more closely these new columns. So I've highlighted columns 6 through 8. And starting with that column 6, for every record, you must provide the Medicaid ID number. And so for a newborn baby born to a Medicaid eligible mother, you are to enter the mother's Medicaid ID in this column. And then so for column 7, requires the provider to enter the Medicaid eligibility program code the recipient is eligible for on the days claimed in the exhibit. So if the patient is eligible for more than one code, you're to report the additional state plan codes in column 18 that you'll see on the next slide. And so related to that program code for column 7, column 8, the patient population code, you're to identify the unique patient population code to identify a restricted or unrestricted Medicaid eligible day. So for restricted eligibility, you're to use code R1 for pregnancy and labor delivery services. R2 represents a code restricted for emergency services. And then CMS then gives the hospital R3 through R9 to define any other restricted Medicaid eligibility codes. And you're supposed to define those codes in column 18. And in the same way, if the code is unrestricted, you're to enter code U1 for general and use a code U2 through U9 for user-defined unrestricted Medicaid eligibility codes. And again, provide those definitions for those in column 18. So kind of stepping back, what does all this mean? First point would be that CMS is expecting Medicaid eligibility for all claimed DISH days. Providers should review how you are calculating these days and do you have eligibility for every patient in your calculation? If not, why not and what can be done? What kind of audit risk does this create? Not only do you need eligibility, but you need to be able to understand the program code the patient is eligible for. You know, each state can have hundreds of different program codes that constantly change over time. Hospitals or their consultants will need to make sure they understand every program code for each state, and those with knowledge in this subject can attest that these program codes and their allowability in the DISH calculation is not something that is made readily available to providers. There's no one website that you can pull up that defines each of these programs. So significant effort must be made to review each state's Medicaid manuals, clarify questions with state contacts, and make individual decisions on whether program codes meet the requirement for inclusion in the DISH calculation and for that individual state for that patient. And these steps need to be repeated frequently as these program codes can change and morph over time. So moving on to the remaining columns in the DISH template, I've highlighted a few more of the new fields. Columns 10 through 12 are ones that you'll need to pay special attention to because when you're dealing with a mom and a baby, you'll need to understand the differences on where to populate certain categories of days in this template. So under the mom's record, any newborn baby up to the mother's discharge date are included in column 12. Any subsequent newborn baby day after the mother's discharge would have to be included as a separate record, and those additional days after the mom's discharge would be included in column 10. So there would be scenarios where you could have days for the mom in column 10, an L&D day associated with that mother in column 11, and then the newborn days in column 12. and sometimes even an extra newborn record if the newborn stays longer in the hospital than the mother. And all of this just adds a layer of complexity and requires the provider to make sure no days are duplicated within the template or days inadvertently excluded by kind of putting days in the wrong bucket. CMS is also wanting information regarding Medicaid eligibility for any claimed DSH days in column 15 through 17. Now, if patients had Part A eligibility on their dates of service, those shouldn't be included in the DSH calculation anyways. But CMS is wanting you to document Part B only accounts or accounts with Part A eligibility but not covering the patient's dates of service. So kind of moving on, changing gears to worksheet S10 revisions. S10, as Mike mentioned, probably has the most significant changes as part of this transmittal, and it starts with the creation of an additional S10 worksheet called Part 2. Now, Part 1 is the current S10 that captures all of the charges for the entire hospital complex, and Part 2 is a subset of Part 1 data that only captures the inpatient and outpatient services billable under the hospital's provider number. So Part 2 would exclude your SNF, your psych, home health agencies, end-stage renal disease, or any other unit not billable under that hospital's provider number. This new Part 2 calculates a new cost to charge ratio, new charity care cost, the total and Medicare bad debt costs just for the acute portion of your hospital. So this will be an additional burden for providers to ensure that when you are carving out this data, that it's done accurately. Hospitals may run into issues just trying to use the discharge location of a patient, as accounts may transfer or have a subset of their charges associated with non-acute versus the acute portion of their stay. It may be necessary to dive into revenue code charges associated with the various cost report units at the hospital to accurately break out these charges on this new S10 report. And the big question is, will they begin using this report in future rulemaking to calculate a hospital's UC payment? Only time will tell if they make that change, but in a comment accompanying this transmittal, CMS explains that it will consider using the data in Part 2 to calculate uncompensated care payments to hospitals in future years. So it's something to certainly look for in the future, and something that seems to be headed that way. So right now, we would encourage providers to begin reviewing how this could impact your individual hospital. You know, do you have a lot of non-acute charity and bad debt in comparison to other hospitals? What kind of impact will this have on your future UC payments? And how can you begin to plan for this change? Is there anything in your charity or collections policy or anything procedurally you need to look at now to better prepare yourself for this potential change? And besides the addition of a new report, there are also several clarifications and expanded instruction sets within S10. The first I'll highlight that is CMS's definition or criteria for charity care on S10. This is something we still consistently get asked about, and so they've now added to the instructions, and I'll quote, CMS does not mandate the eligibility criteria that a hospital uses under its financial assistance policy. The hospital establishes ultimately the criteria for charity care, and it's that criteria in your written financial assistance policy that drives your charity care reporting on S10. CMS has also added language that the uncompensated care must be for medically necessary services. You know, we certainly know that some policies might give discounts for other charges, and while that is certainly the hospital's prerogative, however, in those situations, only medically necessary services can be included on worksheet S10. They've also added language regarding not claiming patient charges for services that were paid for by the HRSA COVID-19 fund, as we've seen that be a point of emphasis on the last few rounds of S10 audits. And CMS has also expanded the definition of courtesy allowances and other exclusions. A lot of these have been brought up before in past Q&A documents CMS released. But one thing that I think CMS is seeing is that especially items like employee fringe benefits and personal health programs can sometimes get mistakenly captured into S10 depending on how those transactions are coded and mapped. And so it's something to pay special attention to, as to not commingle charity discounts pursuant to the written financial assistance policy with other discounts or adjustments. So CMS has redefined what constitutes a contractual relationship with these new instructions. They've updated the instructions to state that a contractual relationship between an insurer and provider will be inferred where a provider accepts an amount from an insurer as payment or partial payment on behalf of that insured patient. Now, in certain scenarios, this might change where discounts were previously recorded as uninsured line 20, column 1, as they may now be included in the insured line 20, column 2. So this is something to keep in mind when we get into these cost reports. And again, these are cost reports beginning on or after 10/1/2022. There's also a new line, 25.01, that's added to S10. This new line relates to charity care charges that represent the insured patient liability other than deductible coinsurance and copayment amounts. And so these charges are actually subject to the cost to charge ratio, but they're actually reported in line 20, column 2. So the first thing we would recommend, you make sure you know absolutely where these charges are being captured right now in your S10. It's very easy to make the assumption that any charity write-off after insurance activity is related to coinsurance, copay, or deductible amount. That's not always the case. There are many examples where it's not related to one of those three, and those dollars should be subject to the cost to charge ratio. We see it in our analysis of HICRIS after each S10 audit that the largest percentage showing in dollars comes from the insured charity, as auditors are finding errors in sampling and extrapolating those results as hospitals cannot support their reporting. So this new line will be a large red flag if there are no dollars associated with charity discounts in this new line, as more than likely that will indicate that the insured charity care dollars are overstated. There's now 3 different scenarios of non-covered write-offs and where they should be captured on S10. First, you have your Medicaid non-covered, and that's still reported on line 20, column 1. You have your non-covered non-Medicaid will now be reported on this new line 25.01. And that also will be included in line 20, column 2. And then you have your Medicaid exhausted or length of stay limit charges, and those are reported on line 25 and also included in line 20, column 2. So hospitals will just need to make sure that they can capture all of this data properly. So moving on from the new instructions, the other big changes are there are now 2 new required templates for charity care and total bad debt. Exhibit 3B is for charity care charges, and Exhibit 3 is for total bad debt charges. Both these templates are required for DISH-eligible cost reports beginning on or after 10/1/2022. So here's a copy of the new charity care exhibit. Right now, there is no defined template, so this is a major change in the amount of data that is required at the time of cost report filing. So looking closer at the template, this mirrors many of the MAC audit templates we've seen in the past few years with some changes. You know, one of the first questions before we get into those changes is in regard to if these templates will impact CMS's decision to allow revisions to S10 lines during S10 audits. You know, one of the issues we run across each year is that these S10 10 audits are taking a considerable amount of time from start to finish. And it's certainly why you see some of the MACs have already started the fiscal year 2021 audits right now that are really not due to CMS until the end of the year. For a good number of the providers, the MACs still see major revisions to what is filed on the cost report. And some hospitals are taking a considerable amount of time completing these templates at the time of the original audit request letter. So I think hospitals need to begin to consider how having this data ready at the time of the cost report submission may impact the ability for future revisions. CMS is making a concerted effort to have all of the necessary data at the time of filing and then in turn audit. So it's something to consider to make sure you're putting the necessary resources into this original as-filed filing. So highlighting a couple fields from the template, there's an insurance status field that you'll enter not only uninsured or insured, but also 2, which is insured but not covered for various reasons. That classification goes back to some of the information we talked about on the previous slides. Column 11, I'll highlight. It's another one. CMS is asking for hospitals to provide the deductible coinsurance and COA payments amounts for each insured account. That gets back to how crucial those fields are in the reporting accuracy of Worksheet S10, and it's something that MACs are now requiring in their template. So most of the remaining columns on the charity template are used to reconcile the accounts from total charges less all activity to get to your write-off claimed on S10. However, there are some inherent issues with this template. For one, it states that coinsurance, deductible, and copayment amounts are to be subtracted from total charges along with all the other activity. So if you do that, the insured charity accounts would never reconcile, as insured charity only deals with coinsurance, deductible, and copayment amounts. So the template also doesn't contemplate for multiple charity write-offs that occur within the same fiscal year for one account and how those are to be recorded on the template. So setting aside some of those major issues, but kind of just looking at, what are the other struggles from this. I think the other major struggle that still plagues a lot of the S10 audits when MACs dig into those templates is that it's very difficult, depending on the patient financial system, to pull out the activity and to 100% record all activity in the appropriate field. Hospitals typically have thousands to tens of thousands of charity write-offs in a year. And while maybe the majority tie out, there are usually hundreds to, in some cases, thousands of anomalies that can cause issues with how to separate the charges. Post-filing activity can change how an account can look now from when you reported the charges. Professional fees and how they are commingled with other charges can cause issues. Write-offs and reversals and subsequent write-offs can all impact on how you compile this activity. CMS has also added separate columns for uninsured discounts, non-covered charity discounts, and other discounts. And this just adds to an already complex set of data points, and it requires the hospitals or their vendors to have sophisticated queries to ensure that this data is reported accurately. So here's a copy of the total bad debt template. It's Exhibit 3C. It's with a total of 17 columns. There's no requirement for any patient detail, but that will change with the new cost reports. Reviewing the template kind of mirrors the charity template in many of the same ways, with the demographic information, the insurance status, along with the reconciliation of each account. Then here you can see that you start with the total charges less all that activity to get to the patient bad debt write-off amount. So the same issues of reconciling accounts I went over in charity would apply to bad debt. But I wanted to highlight a couple of the columns as I think they can get confusing as you populate this for the thousands of records who are written off to bad debt in a given year. And remember, this is the total bad debt. We'll get to the Medicare bad debt template later. So column 14, that's the patient charity amount. You are to enter the portion of the patient's charges written off to charity care regardless of the write-off date. So many times you might have charity write-offs that span multiple fiscal years, but CMS is asking for all those to be grouped into one. Column 17 is another one I think needs to be highlighted from this list. And I'll just read the instructions and then we can dive into the challenges. Column 17, you are to calculate the net patient bad debt amount by computing the ratio of total charges to total charges plus professional charges. You apply that ratio to the total payment, discount, and allowance, and then subtract the resulting amount from total charges that were in column 10. Now, some of your systems might not have pro fees commingled with hospital charges, but where you do have this situation, you can see the complexities that will cause in trying to apply this ratio and reconcile the account. This doesn't take into account any scenario where you know by reviewing the EOB and remit that the amount written off to bad debt is only related to hospital charges and no ratio needs to be applied. CMS does not seem to contemplate these scenarios and how they could impact filling out this template. And it's also interesting to note that the scenario of how calculating ratios is not mentioned in the charity template, but the same rules would apply regarding not claiming pro fees in S10. I think that leads us to our next polling question, Jamie.
Polling question number 2 is, given the new requirements and definitions covered thus far, how would you rate your comfort level? A, have not dug in yet, still reviewing. B, somewhat comfortable. This seems more straightforward, but I am unsure about S10 data mining and full account reconciliations. C, very comfortable. We have been preparing since the initial draft of these changes was issued by CMS. Or D, not comfortable. We would like to schedule a time to talk further. As a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. And we've received a handful of comments about sound. You can refresh the player console by pushing F5 on your keyboard or refreshing your browser. It sounds like most of you have gotten it fixed, but if the problem persists, try closing the browser window and then relaunching the webcast. We'll give it about another...
Sorry, Jamie. Jonathan, while we're waiting, there's been a couple questions about, still a little bit of confusion about who's included and who's not included in terms of both 3A, B, and C, the main hospital and other components and subcomponents, or in the case of 3A, which hospitals are required to complete the exhibit and which hospitals are not. Do you want to just do a brief cover that again while we're waiting for these answers?
Yeah, I can at least start with, the requirements of completing the Medicare DISH template or the charity care template and total bad debt templates. Those are hospitals. Any DISH eligible hospital is required to complete those, beginning with cost reports beginning on or after 10/1/2022. The only exception of a DISH eligible hospital that wouldn't need to fill this out is if they're hospital specific, their sole community payments are higher on the cost report that they're going to file than their DISH, DRG, federal, those payments. That's the only exception. Every other hospital would have to comply with filling out these templates. And when you get to the breaking out the different elements, you will have to break out the different elements between the hospital only part 2 basically and the part 1. So you will have a subset, a template for basically each. That's the total facility charges, and then one that's just the hospital of the acute. So there will be a lot of templates you're filling out, and filling them out depending on what kind of units you have. So, all right, Jamie. So it looks like we've got the poll results, and kind of this is kind of what we figured. There's these obviously just came out, and I know a lot of the provider community is still kind of trying to get a handle around the new instructions, and a good mix. I think this is a good start to hopefully get kind of starting to understand the complexities of the template, and certainly as we get into more of it, we can dive into even more of the individual columns. But I think you start to see just how much PHI data and how you have to carve it out, parse it is a big undertaking now, with the DISH template, the new S10 templates, and then a much more robust Medicare bad debt template that we'll get to. So I think we'll get to the last of my sections, which was the Medicare bad debt and the revisions that we saw from Transmittal 18, specifically the new template. The template's been replaced. The Exhibit 2 has now been replaced with the Exhibit 2A template. The current template has been expanded from, I think it had 10 columns. It's now 24 columns of data for each record. But there's certainly more involved than just adding additional information, as some of those require additional logic and can be a challenge to pull out of your patient financial system and apply that correct logic. And as we continue to see system conversions, one thing to keep in mind is how this data can be extracted from your legacy system based on the timing of when you claim uncollectible accounts. We know there can be, a year, 2 years between write-off to claiming them, depending on your policy and just how that's pulling out of the legacy system. So that's something to keep in mind as we get into the years where these will be required. So here's a copy of the new template. Again, 24 columns. I know it's somewhat kind of hard to see some of these, so let's get into looking at some of the new fields. And I've highlighted a few of the new fields. One is the requirement to include the Medicaid remittance advice date or the secondary payer remittance advice date. That's the 10 and 11 column. And I'll show a couple of the other new fields in the next slide. But the point is that these additional fields really should result in a smarter audit. So auditors will be able to perform calculations within the worksheet to check for some timely billing, minimum collection days, or other checks where previously this could only be done through additional sampling at audit. So what you're doing is obviously providing MACs with more information, and they can use that during their audits, not just through their few sampling, but can really do a full review of your Medicare bad debt. So moving on to the second half of the new columns, for column 14, you are to enter the date the Medicare beneficiary's liability was written off to AR. In columns 15 through 17, ask the date it was sent to collections, returned from collections, collection efforts ceased, and ultimately the Medicare bad debt or the Medicare write-off date. The instructions state that these may all be the same date, but they may be different depending on your policy and how you're accumulating these. Column 18 is reporting of recoveries, and column 19, which is recoveries only Medicare FYE date. That column is actually optional. Obviously, that's just when you're recording what fiscal year when the write-off was recorded. Column 22 is another new one. Are the payments received from the beneficiary, their estate, third-party insurance related to the deductible and co-insurance amounts in columns 20 and 21. And then finally, you get to your column 23, which is your actual allowable bad debt amount recorded on the cost report. and that should be less than or equal to the sum of the amounts in column 20 and 21, less any payments in column 18 and 22. Obviously, less any recoveries received, and less any payments received. So, kind of just to wrap up these uncompensated care reports, these create a couple different pain points. I think the first one, obviously, is to build new processes to address these new reporting rules. But this also creates another pain point in that auditors will also be navigating these new templates, and that the hospitals will need to be ready to explain, defend their data, and ultimately the new questions that will come from these new templates that will change the landscape of the audits moving forward. So all of this needs to be taken into account beyond just the necessary pulling the information and reporting this accurately on the reports, but really being prepared on how this can be used in future audits and what to look for and what are your audit risks at your individual hospital. I think that actually leads us to our next polling question, Jamie.
What recent changes are you most concerned about regarding Medicare bad debt? A, new template. B, documentation requirements at audit. C, accounting treatment changes. D, I don't know. Or E, no concerns. My vendor will handle this. Once you've completed all the CPE requirements, you'll be able to download a PDF of your certificate from the CPS progress window. We'll give it another minute or so, and then we will see what the results are.
We had another question or two. Just wanted to clarify when these instructions are effective. So just for clarity, they're effective for cost reporting periods beginning on or after October 1st, 2022.
All right, let's see what the results say.
Well, that's pretty even results, I guess, across the whole board. I think, obviously, specifically the new templates and the new fields, I think I certainly see those as challenging because it's certainly not as easy as just pulling a couple extra fields out of the system. There is some logic in a couple of the data sets and what you need to look at, and that kind of bleeds over into some of the documentation required at audit, especially the last couple of years of what they put in the rulemaking and really how that looks. So I certainly see that as challenging too. So I think Eric, now it's your turn.
I'll take over from here. There's quite a few edits throughout the cost report. Most of them will affect a small group of hospitals. I'm going to talk pretty quickly about some of those changes so that you're not surprised when you're doing the reports this year or looking at the reports this year, and try to make up a little bit of time given all the great questions about the first section of this presentation. The first is the GME payment calculation correction for the 2023 IPPS regs. CMS indicated they're going to fix a penalty that occurred when the weighted FTE counts exceeded the GME FTE cap. The correction for those is now included in the cost report on worksheet E4 and worksheet S2 in order to ensure that you get the greater of and get your FTE counts up to the FTE cap. Although thing to point out, less of a change and more of an update, which is that the low volume adjustment Medicare dependent hospital programs are extended through 12/31/2024. It's unfortunate, but we're kind of on this update every few years right now, but we have a little bit of room for the next couple of years. Cellular therapy acquisition costs include a addition of new worksheets, worksheet D-6, parts 1 through 4, have been added to account for the acquisition costs of allogeneic stem cell acquisition. Works very much like organ acquisition costs. It's reimbursed on a reasonable cost basis, and the worksheets calculated in a very similar manner. And through the public health emergency, many hospitals had to add temporary beds. The cost report has been updated to account for these additional temporary beds so that they don't disrupt other calculations in the cost report. So now on S3, you'll see at the very bottom a line indicating room for temporary beds and identifying the Medicare, Medicaid, and total days within those temporary beds. And that will go through the public health emergency. For the very few hospitals that continue to receive the TEFRA target amount that are non-PPS, those that have gotten a approval from their MAC for a permanent adjustment to the TEFRA target amount now have a place on the cost report to include that for future reporting. And the Consolidated Appropriations Act of 2021 added the opportunity for additional FTE slots and some workarounds to the per resident amounts and cap limitations. Additional lines have been added to E4 and worksheet E to include those changes. So now the additional slots awarded are included on a separate line, as are cap limitation adjustments for rural track program and any resets to FTE caps and per resident amounts. So they're all isolated in the reporting itself to show the application. Some other updates, the worksheet A, B, and C include a new line, CAR T cell therapy. So this is relatively new. And as some of you know, some of the pharmaceuticals related to this are in pass-throughs at this point. They are isolating these costs on a separate line for costs and charges to be able to track the amounts better for future rate setting. There's also a description change on several of the line items that you'll see where it says chart hospitals or community health access and rural transformation hospitals. This is a demonstration project for rural ACOs and hospitals doing value-based transitions in their markets. It will only affect those within those particular markets. There was additional language to add that they added to central services and supplies and pharmacy costs. These aren't new to anybody in the cost report, but it is noted that they've added quite a bit of language to make sure that hospitals follow prescribed methodologies for identifying the costs within those areas appropriately and allocating in a consistent manner from what they're expected to the cost report itself. And then finally, I would say they've added the contractor worksheet to do the outlier reconciliation to the cost report. The MAC has been doing this work for several years, as we know, but it's notable that they've added this additional worksheet at this point in time. So perhaps we'll be hearing more about additional outlier reconciliations in the future. With that, we have our next poll question. Jamie?
Every 3 years, providers reimbursed under IPPS must complete an occupational mix survey, which is critical to the calculation of the hospital's wage index. How would you rate your comfort level in preparing the survey this year? A, very comfortable, B, somewhat comfortable, C, not comfortable, D, I don't know or not applicable. For those of you that would like a copy of today's slides, you can download them from the folder that says slide deck and handouts. We will also be sending the slides via email tomorrow, along with a recording of the webcast. Looks like there's answers still coming in, so we'll give it another few seconds. And then here are the results.
Well, that's fantastic. This is one of those things that every 3 years somebody has to dust off what they had done in the past and make sure that they remember how to properly do the occupational mix. We have a few repetitions of doing this work, and it's good to see that so many of you are feeling comfortable with this approach and ensuring that their wage index is going to be appropriate. So thank you. Mike, I'm going to turn it over to you.
Thanks, Eric. We've got a little time, so I thought we maybe as you can imagine, there's a lot of questions. There's a lot of questions related to just sort of the technical aspects of completing the exhibits and obtaining the data. But one I wanted to throw out, Eric, maybe you can help a little with this, and Jonathan as well. There's obviously a lot of questions about the level of PHI that's required in these templates and concerns about transmission and protecting this information and so forth. I don't know how much guidance, if any, has been submitted yet with regard to transmitting that, or if you can relate it to, some of the transmissions hospitals already do through the current cost reporting process with regard to Medicare bad debts and the DISH and charity templates that they've been asked to submit to date. So I'm just going to throw that out to one or both of you all to maybe talk about.
Cool. I'll let Jonathan take that.
Yeah, I mean, I can tell you this, that, obviously all these MACs having all these portals now, it's a major concern. We see it, just recently in all the S10 audits that, that we do, just the massive amount of PHI. And so I know the MACs portal usage and just having those and having those set up correctly and being able to transmit and receive through those portals is kind of key in all of this to make it a smooth process. And it's something that I know they continue to evaluate on how the data is transmitted to them.
Another item is what is driving these DISH, S10, and Medicare bad debt changes? Has there been audit issues in prior years? And I'm happy to speculate on this as well. Obviously, not being inside the inner workings of CMS, but I think if you've been around long enough, what you do see is CMS does take opportunities to try to learn from the information that they're seeing. For this S10 was actually included in the cost report many years ago before any of that information was used for anything, but you just knew when those worksheets were created that at some point that the agency was going to do something with that information, and whether they knew about it at the time or not. And then we know that at the very beginning, the audits of S10 began with just a percentage of the providers that were included in the Factor 3 file, or just roughly 25% of the 2,400 hospitals, and that has obviously now expanded to all hospitals. And based on the work that we've done, you can kind of see a progression of items that are being looked at from year to year relative to the results, from the prior year. So if you look at the work that was done on, say, total bad debts that were reported on worksheet S10, and say the initial audits, it wasn't as robust as that work is being done today. And as CMS continues to refine its approach to things, then I think it does shape the way things are being asked for. So I do believe in part that certainly is the case as they try to work on this. Let's see. There was one question about whether or not there was any information regarding the continuation of the Medicare dependent hospital status. That was not a portion of this transmittal. That's something that that would be handled in separate rulemaking. And then there were just a number of other specific items, some, again, following up on what cost reporting period this will be effective for, and that's for cost reporting periods beginning 10/1 of 22 or later. We will go through the rest of these questions, and we will produce a Q&A that we can send out to everyone that participated in the webinar today, and we'll also reach out individually to those of you that had some questions that are specific to your situation that may or may not be shared. But I would kind of wrap up by saying, we know from the hundreds of engagements related to these items that we prepare for clients, it takes a team, it takes time, and it requires additional quality controls to ensure that the correct information and all of the correct information is obtained. And you all know how challenging that is, as there have been such significant transition to new systems in hospitals, not just during the last several years, but even in years beyond that. So as you continue to contemplate what to do here, and there were some questions around this, one thing we offer is definitely put together a team. This is the kind of thing that should include people from reimbursement, the accounting department, your patient financial assistance services group, definitely decision to support and IT, and also those in administration that are responsible for the development of your written policies, specifically your financial assistance policies and your collection policies, and kind of start with that group around the table talking about what you have and what you're going to be required to report, and how to ensure that you're getting all these pieces teased out of your system and report them properly. I would suggest one of the first things you do after this call is to get some subset of that whole group together and do a gap analysis of what you're doing now and how you're obtaining the information you're obtaining to complete what you've been required to submit with the cost report, which has been kind of a subset of this information, as well as what you've been experiencing through audits as you've been required to submit, some significantly more information, but so far just for the sample patients. If you've not done a full assessment of all your financial assistance policies yet, or in a while, this is a good time to maybe stop and add that into the mix as you look at this sort of next iteration of things you have to report. As you could imagine, there were a lot of questions about, well, what if I've got DISH, and what if I have Medicare bad debts, and what if I have regular bad debts, and who's crossing over from kind of list to list, and should I include this patient or should I not include that patient? A lot of that, particularly as it relates to charity care and non-Medicare bad debts, is driven by your policies. So to the extent you can ensure that your policies are tethered to your transactions and vice versa, then I think you can manage the quality of the information that you provide. And then from a decision support and IT perspective, I certainly would sit around and talk about how to leverage the request of all this data. There's a pretty significant amount of overlap between the information you need to complete the DISH S10 and non-Medicare and Medicare bad debt schedules. And I think to the extent that you can work on how you obtain that information from your system and kind of keep everything straight, so you've got a good sense of where it's coming from and how you're getting it. And then my last advice would be to really do an honest assessment of the effort that's required here versus the use of your team's time. And if outside help is warranted to pursue some or all of this, this is a pretty heavy lift. And, empirically justified DISH for the 2,400 hospitals that qualify, it's still $3 or $4 billion, and the uncompensated care pool is, $6 billion plus. So a lot of payments at stake here, and there's some changes that are being made that are likely to result in the redistribution of some of these dollars. So getting off to a good start at the outset of reporting this and as Jonathan mentioned, and anticipating where this might be going in audit is a good place to be. So with that, we're just over time. I want to thank you for participating. Hope this information was helpful to get you underway, and we'd be happy to talk to you further if there's anything else we could do. Jamie, if you can close us out.
Thank you, Mike, Eric, and Jonathan, for a great presentation today. Just a couple final housekeeping items. In the upper right-hand corner of your user console, there is an image that you can click to be taken to the registration page of an upcoming webcast that might be of interest to this audience, Occupational Mix Survey, Prepare to Complete in 2023. It'll be on March 14th. If we didn't have time to answer your questions, we'll do our best to follow up after the webcast. You can also reach out to our presenters if you have additional questions. Their contact information is also in the console. As a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in your console. If you met all CPE requirements, your certificate is available to download now in the CPS progress window. A copy will also be emailed within 2 weeks should you have any difficulty downloading it. Finally, here is a link to an online survey for today's presentation. Thank you for joining our webcast, and we hope that you'll join us again next time.